because we have a and then we don't. You just can say I'm Professor Lemke from Zurich, and then I will introduce the first speaker.
It's such a nice presentation for you.
Morning, everyone. We would like to go on with the next session, session 6 of this program about endometriosis and dysmenorrhea. I have my co-chair next to me. This is Professor Gabriele Murky from the University Hospital of Zurich. And she was previously board member of the European Society of Contraception. And we will hear her later today. And I'm Evelien Roos. I'm one of the Fiji board members, also scientific committee member of this Congress, and the next European president-elect.
Thank you very much. It's a big honor for me to introduce the first speaker, Professor Mark Laufer from Harvard Medical School in Boston. He had made and published a lot of very relevant research and interesting research questions about endometriosis during adolescence. I highly recommend you to read his recent publication on the genetics basis of endometriosis and comorbidities with other pain and inflammatory disease. I hope he will tell us about this. Please start with your presentation.
Good morning. Thank you very much for the opportunity to be here today. I want to thank the organizing committee and my friend Zoran for the invitation. Doesn't seem to be moving forward. There we go. My disclosures are here from our textbook, from advisory boards, and up to date. I do have a personal disclosure that I have laryngeal dysphonia and spasmodic dysphonia, so my voice comes in and out depending on where I am in my Botox cycles. So thank you for bearing with me, and thank you for the microphone. So let's talk a bit about dysmenorrhea. There are other speakers who are going to be talking about dysmenorrhea to follow. But as we begin, it is very common for an adolescent to have pain with menstrual cycles. The question for me, and one question I pose to the audience, is how do we differentiate between primary and secondary dysmenorrhea? Primary dysmenorrhea is, by definition, the lack of an existence of another disease. The challenge is, if you don't look for that disease, you may not know it's there. So we typically use hormonal therapy and non-steroidal anti-inflammatory agents. The question is, if there's a persistence of pain on the hormonal therapy and non-steroidal anti-inflammatory agents, what do we need to do to validate the young woman's pain and obtain a clear diagnosis? We don't want to normalize symptoms. A woman can have pain, and if she's not validated and persists with pain, it can lead to poor quality of life. So we all know the symptoms of endometriosis can vary. They can be none. They can be pain with periods. It can be GI and GU symptoms, or there could be infertility. The coexistence or co-occurrences with endometriosis are many, and we widely believe that endometriosis is an inflammatory disease. Here are some of the recent papers that our team has published on association specifically for adolescents with endometriosis, pertaining to GI symptoms and migraines. It's important to keep in mind the prevalence of the disease. 10% of the population has endometriosis, and it's also very important to remember that if an individual has a first-degree relative with endometriosis, her chance of having endometriosis is 7 times greater. The burden of disease can be a challenge. It can be difficult for our adolescent clients to speak up and share their life experiences. We do have pain scales, depression scales, and quality of life scales, but we rarely use them in a clinical situation, and they're mainly used for research. So we've developed a tool to try to help young women explain what their life experience is. And so with this chart, A young woman can graph her pain from 0 to 10, whether it be cyclic or non-cyclic, whether she has vaginal bleeding, irregular bleeding, GI symptoms, energy or fatigue, state of sexual well-being, how it's affecting her school or social interactions, and emotional well-being. And as closest to the inside of the circle is 0 and going to 10 on the outside, we can follow a spider diagram, and you can note that she's doing worse as the numbers appear further out on the scale. And closer in, you can track how she's doing, whether it be after surgery or after a medical therapy. And this is available for your utilization. The diagnosis can be a challenge. Why? We have no blood test. Many of us around the world are studying inflammatory markers to try to create a blood test, but there is no single reliable test at this time. More challenging is the fact that early stage endometriosis, which we see in young women, may be different from that of older women or more advanced disease and have a different profile. There is no imaging study for diagnosing superficial peritoneal endometriosis. So how do we proceed? When I started in this field 35 years ago, I was told that a woman should be on oral contraceptive pills for 6 months. If her pain did not get better, then we would look for further. The challenge there is to ask a teenager to suffer for 6 months is very challenging. It may affect her ability to participate in school or functionality. And I'll say that was before I had my own daughters who are now adults, and I've lived through adolescence with them. And I know that if you have someone suffering in pain for 6 months, we should act earlier. So we began to ask, is there really a difference between 3 months or 6 months of therapy? No one has done these studies, and it's something to think about. What if you use continuous hormonal therapy? And when do we proceed with the laparoscopy? Those are some of the questions I'd like us to address this morning. Can we make a clinical diagnosis? How can we make a clinical diagnosis? And should the algorithm change if there's a family history of endometriosis or infertility? So this paper was a call to action, internationally published collaborative study looking for a call to action on clinical basis of exam, history, and imaging in an adult population. There is, not all women around the world have equal access to surgery, and should they then suffer without a diagnosis? And I'd like to encourage you that we can make a diagnosis without surgery. So this is an algorithm I put together. I actually did this just for this meeting. It is specific for adolescents. It is adapted from what's in our textbook, but it is really looking at a history of physical examination if one is to be performed. Radiologic imaging may or may not be helpful, as I mentioned earlier, that one cannot see early stage peritoneal disease on imaging. So if the pain persists, we make a diagnosis of endometriosis. Let me say that again. If the pain persists on cyclic hormonal therapy or hormonal therapy, we make a conclusion and give a diagnosis of endometriosis. We can then choose to manage that disease with surgery, hormonal, or hormonal therapy. So we can go to continuous hormonal therapy. We could go to continuous progestin therapy. We could use GnRH agonists or antagonists for those who are over 18 or considered the best line of therapy. But if pain persists, you can see it comes back to a laparoscopic procedure. There's a wide concept going around on social media about the need for one good surgery. What does that mean? I was at the World Congress of Endometriosis last week in Edinburgh, and there was great discussion about one good operation, whether it be excision of deeply infiltrative endometriosis or destruction or excision of superficial disease. There is no right answer to this question. We do use hormonal therapy to suppress all clients with endometriosis, since there is no medical or surgical cure for endometriosis. Historically, surgery has been the gold standard for endometriosis in adolescents for diagnosis and management. We, as adolescent providers, need to make sure that if we are doing a surgical procedure, we're able to identify and approach the lesions. One of the earlier studies I did in my career was looking at adolescents who had pain on 3 months of hormonal therapy, who did go for a surgical procedure. And we asked the question, if they did have endometriosis, what were the symptoms that they presented with? What was unique about this study is at the time, endometriosis-associated pain was typically described as cyclic. What we found in the adolescent population was that it was both acyclic and cyclic. And if you're looking only for cyclic pain, you're going to miss the majority of adolescents with pain. How often do we find endometriosis? If we do a laparoscopic procedure for those who have pain on hormonal therapy. And so we did the study in 1997 and found 69%. John Rock did the same study in Atlanta, Georgia, and found 67%. So it was not just me as a surgeon in Boston, it was not just Boston women. But that number has changed greatly over the years. Why? What's the difference between 1997 and 2012? Well, we developed high-definition technology. We all know about high-definition TV, and it is the standard now, but it was not the standard in the 1990s. And as we see better now, we can see more lesions. So how do we do that? Is it surprising that teenagers have such pain, or that they have endometriosis as a teenager? No. This study of 4,000 adult women who asked them, when did their pain begin? 50% had pain starting at 24 years or younger. That means that our job as adolescent providers is to identify the disease early so the women don't suffer and that they don't end up with progressive disease that leads to infertility and a lifelong suffering, pain. There is no correlation between the amount of disease and the amount of pain. Stage 1 disease is the most painful, and that is not surprising as it's felt to be inflammatory. As we can see here in this study, showing that the majority of lesions were clear or red, and those are the most painful, and those are the most common in adolescence. Why do we say that it's an inflammatory disease? Well, this field has really taken off in the last 15 years. Here is a schematic drawing showing the inflammatory cells and the association with endometriosis lesions. And you can see the different cytokines, tumor necrosis factor, that is involved in the process. And here you can see that estrogen in the peritoneum mediates the recruitment of immune cells and neurons and blood vessels with angiogenesis to the endometriosis lesions. That's how we can explain how endometriosis can survive outside of the endometrial cavity. And so these are key factors for future studies and for drugs for treatment of endometriosis. Macrophages and mast cells are recruited and they activate neurite outgrowth and peripheral sensitization, and pro-inflammatory mediators sensitize the nerves and contribute to pain. So it is a complex environment that involved in endometriosis, and that is what we need to keep in mind as we think about different treatment modalities. What have I seen in my career? The youngest patient I've diagnosed is 7. We have written a paper on premenarchal endometriosis. Not surprising, as endometriosis is stimulated by estrogen, which can come before the onset of menses. We also know that there's a more exaggerated immune response in adolescents, as we've seen in vaccines, and we know that adolescents have the more inflammatory type of lesions. So we should individualize therapy. If they have superficial peritoneal disease or endometriomas, adolescents can rarely have deeply infiltrative endometriosis and adenomyosis. So our goal for its surgeries are to retard progression of disease, avoid adhesions, minimize repeat surgeries, and preserve fertility. We should all be able to diagnose and visualize superficial lesions of endometriosis. And the most common ones you can only see if you use a closed tip technique where you put the laparoscope within millimeters of the peritoneum to be able to see the lesions with magnification. We do use a clear tip technique and underwater, as you can see it here, and you can see the lesions of endometriosis that are superficial moving with the current. Also note the small blood vessels in each of those lesions and the angiogenesis that exists. There have been many studies looking at excision versus ablation of endometriosis. The studies have shown significant improvement with both techniques. There's no difference in superficial management for long-term follow-up, but there is a benefit for excision of deeply infiltrative endometriosis. But for superficial disease, we need more studies. Radical excisional surgery or peritoneal stripping should be avoided. Why? We've demonstrated that there's an increased risk of adhesion formation, and thus one would not want to do that, and there's been no benefit shown. My surgical approach is surgery as a tool in the toolbox for management of endometriosis-associated pain. We want to identify all visible clear lesions or superficial lesions and destroy them. We want to excise any deeply infiltrative lesions, limit the lifetime surgical procedures, and hysterectomy should never be offered to an adolescent with endometriosis-associated pain. We do want to offer medical treatment since there is no surgical or medical cure for endometriosis, and we can continue medical therapy until childbearing is no longer desired. The medical options are well known to this group, and I don't have time to go through them all, but I list many of them here for you. But there are no studies showing that one technique is better than another in the adolescent population. The goal is to suppress menses, but what I do want to focus on are some of the recent advances or reports in the literature. We have used the utilization of norethindrone acetate, which is a progestin-only therapy showing decrease in pain and decreased bleeding. One can titrate the dose for amenorrhea, but do remember that it is not an FDA-approved contraceptive. We've also reported on the presence of liver adenomas in women who are using agestin or norethindrone acetate at 15 milligrams daily, even though this is an FDA-approved dosage. So we limit our dosage between 2.5 to 10 milligrams. And it's not surprising because Roger Lobo's paper showed the peripheral conversion to ethinyl estradiol, even though it is a progestin-only therapy. IUDs are very beneficial for young women with endometriosis. There is limited data, though. There are minimal studies, and in this one study, it showed 67% of those using IUD alone had pain and bleeding. And so we typically use combination continuous therapy or progestin-only therapy with the utilization of an IUD. Danazol was used widely for treatment of endometriosis before GnRH agonists and antagonists. We recently reported on its beneficial effects for transgender individuals, mainly because previously it had fallen out of vogue due to the androgenic side effects, including acne, hirsutism, and deepening of the voice. GnRH agonist therapy. We've recently reported on long-term utilization of GnRH agonist therapy and what the treatment options are after therapy. So in this study, we looked at 51 patients, average age of 17.9. 33 participants had stage 1 disease, before, after surgery, before GnRH agonists, 92% were using estrogen and progestin continuous therapy, 45% had used progesterone alone. And the average duration in this evaluation was 9.4 months of GnRH agonist with add-back therapy. 67% of the clients completed 12 months of therapy, but interestingly, 45% continued therapy afterwards for a duration of 31.7 months, with the longest 96 months of GnRH agonist therapy, as long as you're using add-back. How do I approach medical therapy? We suppress all patients after surgery or with a diagnosis of endometriosis. And my most commonly used practice currently is a progestin IUD placed at the time of a laparoscopic procedure, or with sedation for those who do not have a laparoscopic procedure, and then low-dose monophasic combination therapy or progestin only. What are the outcomes and predictors of disease? In this quality of life study, we looked at 567 participants with controls. They answered standard question, short form 36, and what we found was there was significantly lower mental health component and physical components, with more cases than controls reporting mental health diagnoses, pain medication use, and avoidance of physical activity. Among cases, earlier age of menarche, more severe pain, and longer duration of a delay in diagnosis were all associated with poorer quality of life. How about the post-surgical effects? 90% of our clients have one operation, but we looked at 90 patients who had more than one operation. And they had used, after their first operation, standard medical therapy. And then we followed up for those 90 patients who elected to have a second procedure. And we found no disease progression, no adhesion formation from the surgical techniques that we're using. And the standard medical and surgical combination retards disease progression. In this more recent study, we asked the question of, can we predict who will do well after surgery? As you can see, the answer is complicated. Many patients who had mild disease stayed mild. Some had worsening disease over a 2-year period, and some with severe disease improved. This argues for the fact that it's not just the surgical presence of the disease, but also the chemicals involved with the production of endometriosis lesions and how they can affect a woman in many different ways. We've looked at the genetics and trying to identify a biomarker by looking before surgery and after surgery. And this paper found many interesting targets that we will be exploring in the future. And this most recent paper in Nature Genetics involved 140 co-authors from around the world. And we identified a number of genetic markers that can be used. And not surprising, they're involved in uterine development, adhesion formation, and we can use these as possible indicators for targets for future treatments. Endometriosis-associated pain has multiple presentations. It can be inflammatory. It can involve peripheral sensitization and central sensitization, and thus I would encourage you to use a multimodality approach for the management of endometriosis-associated pain. Most importantly, we want to validate a young woman's experience and her pain, talk about coping skills, use medications, pelvic floor physical therapy, cognitive behavioral therapy, and other alternative options. In conclusion, I'd encourage you to listen to your clients. When they complain of pain, we don't want to minimize their experience. We want to make a diagnosis. We want to provide options for management and ongoing support and educational materials. We want to set realistic expectations, since we don't have a cure for this disease, and collaboration internationally to advance the field. For those of you who are not familiar with our website, youngwomenshealth.org, it's been around since 1997. We get about 4 million visitors a month on this website. Currently, it's in English and in Spanish, and I welcome you to use it. It is free, and there's a lot of educational material on our website. There's a recent review article that covers a lot of the material that I discussed today in the Journal of Pediatric and Adolescent Gynecology, and I thank you.
Thank you, Professor Laufer, for this interesting talk. You may sit here on the podium because we are going to take questions at the end of the session, so please hold your questions. Can I introduce the next speaker to you? This is Dr. Judith Dekker from the Netherlands. She works as a reproductive health specialist in Amsterdam University Center, and she is the current president of the WCPAG Society. She is going to talk today to us about dysmenorrhea, the etiology.
Thank you, Evelien. Thank you for the introduction and the kind invitation to speak about dysmenorrhea. A little bit back to the basics. I have nothing to disclose. Then dysmenorrhea. The topics of my talk will be dysmenorrhea, a little bit about primary, secondary, and the etiology, and then a little bit about the pain concept. Dysmenorrhea, it's defined as spasmodic and painful cramps in the lower abdomen during menstruation, and it refers to thousands of years of pain, specifically women's pain, and it's already mentioned on a piece of papyrus as shown here of many years ago. And throughout history, this pain was routinely dismissed as psychosomatic, the result of poor lifestyle management or punishment or delayed pregnancy or just a normal process. Women should mostly suffer in pain in private or well, even abandoned, frequently denied the status of real pain. This changed in the 1900s. In the 19th century, as Lydia Pickham brought an elixir on the market, and the compound was formulated to specifically target women's problems and help to relieve problems of all kinds for women, as premenstrual syndrome, menopause, and also menstrual cramping. Pinkham's vegetable compound became the best-selling drug in the 19th century, partly due to the preserved effectiveness of the black cohosh, and as a matter of fact, it's also contained alcohol, and partly because women trusted the medicine created by a woman for women. And women's pain became more recognized and more public, and more research was done to search for causes. Then, dysmenorrhea. Well, it's commonly divided in two categories based on pathophysiology, and it seems quite simple. Primary, no pelvic pathology. Secondary, with pelvic pathology. And as you can see, there's a huge list of possible causes. And in adolescents, I want to point out some major ones, and endometriosis is the first one. And as we had a very nice talk about this already, I skip this one and then go to the next one. I try to. Yes. And the congenital obstructive Mullerian anomalies are the next one. It's very important, and especially the Ovirus syndrome I want to mention. Ovirus syndrome, it stands for obstructive hemivagina with ipsilateral renal agenesis. And it combines with a bicorporal uterus or septated uterus. And because of the double vagina, this Mullerian anomaly, there are menstrual periods, but due to the obstructed hemivagina, there will be an increasing hematocorpus and therefore an increasing pain complaints in months. Then I come to the symptoms. How can we discriminate between primary and secondary dysmenorrhea? Well, the classic symptoms for primary dysmenorrhea are cramps, mostly around day 1 to 3 in a cyclic pattern and similar every month, lasting no more than 3 days and mostly seen 6 to 24 months after menarche. It can radiate to the back or to the thighs, and other symptoms are accompanied as well as headaches, dizziness, nausea, and vomiting, or other generalized symptoms. In secondary dysmenorrhea, the pain is mostly progressive worsening and can be together with other pain complaints like chronic painful complaints, acyclic pain, and dyspareunia. It can also be associated with menstrual bleeding disorder, just depending on the cause of the secondary dysmenorrhea. It also counts for the start of those pains. But I have to mention that secondary dysmenorrhea can have similar signs and symptoms as primary dysmenorrhea. So it's not a clear line between those, and it's rather a gray area. And you have to keep in mind there can also be a mixed form of dysmenorrhea as well. Then, to discriminate, we can use some diagnostic tools like ultrasound, MRI, laparoscopy, but I'm not going to go into that. But what I want to mention is when and what to do seems to have the best results in compliance and satisfaction if we take into account the patient's or the adolescent's situation and the needs, and those are discussed well, and a shared decision is made. Then the impact of dysmenorrhea is rather huge, and keep in mind that most studies are not differentiating between primary and secondary dysmenorrhea, but the prevalence is around 45 to 93% mentioned, and we find severe dysmenorrhea in around 40%. And the prevalence of school absenteeism is rather high, between 14 and 50%, and even monthly absence is mentioned between 20 and 30%. And besides the absenteeism of school, they're skipping sport activities and social activities as well. So adolescents with severe dysmenorrhea show a lower quality of life compared to their peers without dysmenorrhea. And they also have an increased risk of developing depression and anxiety. Then it's all, but not all, but mostly due to the pain. So I want to go into that pain. Talking about primary dysmenorrhea, the suggested pathogenesis of the menstrual pain starts with a decline of progesterone at the end of the cycle. Lipids build up in the cell walls are released, and particularly arachidonic acid. This triggering the COX pathway and induces the synthesis of prostaglandins and leukotrienes, and especially PGF2 alpha is a potent vasoconstrictor and myometrial contraction causing, leading to uterine ischemia, hypoxia, and therefore pain. PGF2 alpha is also hypersensitized pain nerve fibers and therefore also increasing pain. This model implies that primary dysmenorrhea only is seen in ovulatory cycles, but that's not true. Study shows that there's also primary dysmenorrhea mentioned in anovulatory cycles, so other factors must be involved as well. And studies are done on this, of whether there are other factors involved, though the studies are scarce, but vasopressin might be something that can be involved as well, and it's also found to be elevated in dysmenorrheic women. Vasopressin can also induce vasoconstriction and pathologic uterine contractions. Then, it seems more and more clear that even primary dysmenorrhea can be associated with other forms of pain, like chronic pelvic pain, but the central sensitization I want to mention. Each person's clinical pain experience is determined by a complex interaction between peripheral factors and maladaptive changes in the central nerve system. Increased peripheral input results in an altered brain possession and amplification and generations of all sorts of pain. And women with dysmenorrhea have an increased sensitivity to painful stimuli throughout the whole menstrual cycle. And other concomitant symptoms can be adduced as well, as they have their regions in the same area as pain in the brain, as I can mention anxiety, depression, and insomnia. Those can have an increasing negative impact on life as well. Then I want to come to my conclusions. To differentiate between primary and secondary dysmenorrhea is not always easy, but we have to acknowledge menstrual pain as a real pain. It's very important because it has a high negative impact on life, and it can lower quality of life of the adolescents in a great deal. So beware of a possible central sensitization and a chronic pelvic pain syndrome, and start evaluation and treatment in time, as the other next speaker probably will come into that as well. The only thing I want to tell you, I don't think Lydiopinquin liquid will do the trick, but I can tell you it's still available. So I want to thank you, special thanks to my colleagues, and special thanks to you for your attention.
Thank you very much, Professor Dr. Decker. I think we will have the discussion later, and I'm looking forward now very much to hear something about the treatment of dysmenorrhea, and want to introduce my co-chair, Dr. Ross from Utrecht, who is not only a specialist on adolescent gynecology, but also on urogynecology and epidemiology. And yes, she has been a EuroPAG member since 2017.
Thank you for this kind introduction, and thank you for this invitation by the local organizing committee. And today I'm going to talk with you about treatment of primary dysmenorrhea. Is there something new? Although I have no financial disclosures, I may have rule disclosures. And what I actually like to take you with is that in this map of the globe, you see the prevalence of dysmenorrhea around the globe. And I divide it in the regions, well, we would say in Fiji terms, the big 6 regions of the globe, and looked at the prevalence. Is it different in certain populations? Is it different in different ethnicities? And what you see is that commonly around the globe, the prevalence of dysmenorrhea is somewhere about 40 to 90%. And that means that it is a lot of adolescents, and a lot of adolescents, almost 2/3, report missing at least one day at school per cycle, and 15% of the adolescents report missing more than one day a cycle. So looking to dysmenorrhea and prevalence of dysmenorrhea from this global perspective, it is not something that a few people do have, but a very, very lot of girls. And what we have known about treatment of dysmenorrhea, there are several guidelines, and every PAG society or OBGYN society has their own guidelines of the treatment of dysmenorrhea. And most commonly it's used non-hormonal, the NSAIDs, but also hormonal contraceptives, progesterone-only pills, intrauterine systems. But alternative and complementary medicine, when you look at the literature about treatment, is becoming more and more popular. And then when you look at that alternative and complementary medicine, especially exercise is something that is actually working, but also herbal and dietary supplements like fish oil, vitamin E, traditional Chinese medicine, but also acupuncture. So when there are a lot of options, and it is so prevalent like this, one can say it's a public health problem. How good are we in treating, and how much success do we have with treatment of dysmenorrhea? And we see when we say a first-line treatment for dysmenorrhea is NSAIDs, either combined with hormonal treatment or not, our first line is successful in 75%. That still leaves 25% not being successful. And 25%, when we look back to our first slide of the global prevalence of dysmenorrhea, that is still a lot of girls where we are not successful for. And when we look at failure for NSAIDs, about 25%, it has to do with drug availability, but also in how the body reacts to one NSAID. And we do know that one NSAID is not better than the other one. I will come back to that in a moment. But there are some reasons, and some biological reasons, but also some pharmacological reasons why NSAIDs are not working in certain type of girls. One of the ideas behind that is the role of leukotrienes and platelet activating factors, but also, as my previous speaker talked about central sensitization, that is also a mechanism that is behind the failure of the NSAIDs. So, what our first speaker also referred to, seeing this big prevalence of so many girls around the world, what is the progress of dysmenorrhea into adulthood? And so far there is not so much literature about that. I could retrieve 2 studies coming from Australia with a follow-up of 10 years, which is maybe slightly short. And we found 27% resolution of dysmenorrhea into adulthood. Thinking of the high prevalence, that leaves still a lot of women who had dysmenorrhea as girls, but also will have dysmenorrhea being an adult. What we do see that over time in treatment that we started as first-line treatment, the use of oral contraceptive pill and NSAIDs are decreasing. So what I did, what you usually do today, you look on the social media to see what you can find about dysmenorrhea and how you can treat yourself. And what we do know is that for adolescents with dysmenorrhea, a lot of adolescents do self-medication. And is that actually harmful? Well, probably not. It should have some benefits, like the adolescent can take care of herself. It is an active role, it's self-reliance, and probably from a bigger health perspective, it might be also lowering the waste of medical resources and economic, and therefore not losing money on healthcare expenditure. When we look at NSAIDs that you can buy over the counter, the OTC medication, we see that all NSAIDs, it doesn't matter which type you take, it is all more effective than placebo. And I see on the right-hand side, I made a figure of which NSAID looks a little bit better than the other one, but it's kind of small here on the right-hand side. But let me summarize, in the green box, the message is all NSAIDs are better than placebo. And in the yellow box, we see that naproxen does do it a little bit better than diclofenac or ibuprofen. So, when you are a teenager and you're looking on social media, you know you can take this. But can social media or digital health also be another self-management strategy? And there has been actually published a quite nice study about the smartphone apps, and that were basically the studies from the Apple Store. And they looked at overall app quality in several domains. I'm not completely into the computer science. I need to be very brief about that and very honest about that. But there are criteria how you can see whether an app is actually a good health intervention. And maybe not surprisingly, 40% of the app's development, but also the content of the apps were developed by healthcare professionals and researchers in the field. And there are apps tracking menstrual health, but also there are some apps tracking pain and how you can have some self-strategies for managing dysmenorrhea, basically at home. There is one app that I would like to draw your attention to, and that's the period app of UNICEF. It's called Oki. And Oki is made by UNICEF to promote informations about their periods to girls on every place of the world. And they have been adapted to several cultures. Mainly at the moment it's used in Asia. And it is actually age and culturally appropriate and available in many, many languages. And it also uses digital inclusive languages, which I think it is a way forward. So what they built in is also some cycle prediction, period prediction, and it's actually adolescent girl-centered and gamified app. The last thing I would like to draw your attention to before I come to closure is when I looked on the internet and looked at the global market of dysmenorrhea treatment, you see many forecasts that the global market of dysmenorrhea is going to increase in the upcoming years. And it's not only, when you see on the figure on the right-hand side, it's not only North America and Europe, but it's also Asia, Japan, Australia, Africa. And there are some main drivers for this increase in demand on dysmenorrhea treatment. And one is the increasing prevalence of dysmenorrhea, but also, and I don't know how it's in your region, but I see in this region there is a current more awareness of dysmenorrhea and endometriosis. And there is creating now so much awareness that I will think it will change this, it will drive this rise as well. The other thing is change in lifestyle. It's less done or less normal to cope with pain, but also the lower price of over-the-counter drugs. And when you look on global level, there are, you see here on the right-hand side, there are a few players in new medication, and it's not really new, but, well, we will see. There is hope for the future, I would say. But last but not least, I would like to promote the very good book of Vincenta Bruni and Metella Dai. There is a copy at the registration desk that you can see. And my last message that I would like to actually invite you to be in the next WCPAG Congress in Greece from June 5 to 8, 2024 in Thessaloniki. Thank you for your attention.
Thank you very much, Evelyn, also for being so good in time.
And our next speaker is going to be Professor Murky from Zurich University, and she's going to talk about endometriosis and depression, a less known comorbidity.
I want to thank the local organizers very much to give me the opportunity to talk at this very relevant conference in the wonderful city of Belgrade. You have already heard the topic of my talk, and these are my conflicts of interests. We have heard already a lot about endometriosis, prevalence 10 to 15% in women during the reproductive years. It's a chronic inflammatory disease with chronic disabling pain. Estrogens play a pivotal role. It is frequently associated with autoimmune disease and with depression and other psychic conditions. And what we do know is that the pain intensity does not correlate with the size or localization of the lesions. On the other hand, we are talking today about depression. Major depression has a prevalence of 10% in women during the reproductive years, and I think it is very relevant to take a good history in endometriosis patient to understand whether this woman suffers from a depression as well. But why may endometriosis patients have depressions? I mean, if I see these women or also young girls, I would understand that they have a depression just related to their disabling pain, regular dysmenorrhea, and restrictions in daily function. But how can we identify adolescents with the risk to develop a depression related to their pain? And could we avoid the depression by early successful treatment of the endometriosis? Is the use of hormones for the treatment of endometriosis perhaps a part of the depression the women have? We know that many hormonal treatment can cause depressive mood as well. Or is perhaps the high depression rate in women with endometriosis also related to infertility? Another question, I think this was already mentioned from my last speakers. Would adolescents in your country with severe dysmenorrhea search a specialist for specialized care, or would they just be treated with cane pillars from the pharmacy or parents, and that's the delay of endometriosis diagnosis might prevent early optimized therapy. So how long is the journey to good treatment? I already said major depression in women during the reproductive years is around 10%. It is double as high in women with endometriosis. And here are some data related to the effect of hormonal treatment on mood. We have some data related to the hormone release device, but also to combined hormonal contraceptions and to many progestin-only treatment. So this is a bit crucial for us, especially if we have a young person already suffering from endometriosis and depression. What hormone could we choose? On the other hand, newer data indicate that there is also already on a genetic basic endometriosis and depression share low-key, and this also implicates causal links with gastric mucosa abnormality. But so we might have a subset of endometriosis patients who will easier develop depression just because they have a genetic predisposition. Now, we performed a study in 2021, including all our patients visiting the endometriosis clinic. These were 1,554 visits. We used very strict exclusion criteria to have, in the end, good data. And in the end, we had 225 endometriosis patients without psychiatric disorder and 70 patients with depression, major depression, not any psychic disorder. And we did not see a huge difference with regard to dysmenorrhea start at menarche. Both groups were between 36 and 40% of women who reported that they suffered from dysmenorrhea since menarche. A slightly higher percentage of women reported that they already had dysmenorrhea score 2 to 3 from menarche on. But also this is a trend. You see this group with depression maybe is not sufficient high to find so many significant differences. However, what was significant is that a higher percentage of the women with depression used more than 3 analgesics during their menstrual bleeding, and they reported an insufficient response to analgesics. On the other hand, we found that significant more women with depression suffered from dyspareunia and dysgeusia. Also, both groups did not differ with regard to depth of infiltration or ASRM stage. So the lesions in the rectovaginal septums were significantly more frequent in women with depression. And on the other hand, the women with depression had less ovarian endometrioma, what might, of course, contribute to later diagnosis of the disease, because all other lesions are not seen so easily with ultrasound. And another thing, perhaps of concern and to think about, is that nearly significantly more patients with endometriosis and depression had already experienced more than one endometriosis surgery. What, of course, again, could be caused to the lower response to the analgetics, so we come under pressure to perform more operations. There was no difference with regard to number of pregnancies or age at first surgery. Now, DNO-test is well established, has been well established in the last 10 years as a first choice medication for endometriosis. And we found, with regard to reasons why women stopped use of DNO-test, worsening of mood. This was 8% in women without any psychiatric disorder and 29% highly significant in the group with depression. So if you have a patient with depression, really think clearly about which hormonal treatment you would recommend her as first choice. In conclusion, preliminary data indicates that women with depression differ in endometriosis features from those without depression. Furthermore, they use more analgesics and seem to respond less to these medications. A slightly higher percentage of women with the comorbidity suffers from stronger dysmenorrhea already since menarche. Women with a comorbidity also tend to experience more surgeries. Differences in pain perception, and here I want to come back to the recent study of Professor Laufer looking at genetic overlaps also with regard to pain perceptions might play a role here. And it remains unclear if successful treatment of the depression will result in better response to pain medication and endometriosis treatments. I think this needs also further research. And I hope to see many of you at our next European Society Congress in Bilbao in Spain next year. Thank you very much.
Thank you very much, Professor Murky. We have now 5 minutes for questions. Oh, I see many hands. We will take 2. So the first one to wave, I see there.
Thank you, Evelyn. Thank you for the presentations. I want to know, Dr. Laufer, what is your experience about performed surgery in small endometriomas in adolescent and young adults with respect to ovarian reserve?
So I think the data is limited. The chance of an endometrioma in an adolescent is fairly uncommon in our population in the United States. I think if you look at data from around the world, there are other areas that report higher rates of endometriomas in younger individuals, specifically from Japan and from Brazil. But in the United States, our experience has been lower. Our goal is to remove an endometrioma initially and then suppress using medications and limit the number of surgeries. So if there's a recurrent endometrioma with a known tissue diagnosis of endometriosis, we don't need to worry that there is an underlying malignancy if there isn't a change on imaging. And so we would limit the number of operations in order to preserve ovarian reserve, as you point out.
Thank you. I have another question. In the new ESHRE guidelines regarding treatment of diagnosis and treatment of endometriosis, surgery is really the second-line therapy. What is your experience related to the effectful treatment of pain?
So I think the groups have raised a number of questions, including Andy Horn's paper on a question if superficial peritoneal disease should be managed surgically at all. And I think it really depends on the age of your individual and the extent of pain and the options for management. I hope I made it clear in my presentation that surgery is one option in the toolbox of management. Some patients elect to use suppressive medical therapy without surgeries. Others choose to have a surgical procedure for what they consider a definitive diagnosis, but a surgical procedure is not required for a diagnosis. So in our practice, we do discussion and then informed consent and it's shared decision-making as to whether we proceed with medical management or surgical or a combination of both. But I would say the majority of our younger adolescents choose to have a surgical procedure followed by medical therapy.
Thank you very much.
One question, that's the last one.
Yeah, so first of all, thank you very much for excellent session, all presenters. And my question goes to Mark. Thank you, really stimulating lecture. And you show this publication that once you do a surgical diagnosis and then you treat them medically, and if you need another one, then you see that most of them are progression-free. But my question is, before doing surgery, you give a hormone suppression and you achieve a good pain control. Would it decrease the progression of the disease? Do you have any data on that?
So, Devorah, that's a great question. No one has data on that. So, just to be clear, when we use hormonal suppression, I think the key factor is to give the woman a diagnosis. Many women leave the office and say, I don't know what's wrong with me. The doctor just gave me hormones and told me to stop my periods. I think there is a lot of value in validating her pain and saying, you have endometriosis. We are going to use medical treatment to suppress it. But your question is a good one. We do not have any long-term data on if you use medical therapy alone, will the disease progress? We don't even know the rates of progression of the disease. And the paper that I presented here, one of the criticisms when we went to publish that study was the underlying rate of progression of the disease is unknown. We know that many women progress disease. They aren't born with stage 3 or stage 4 disease, but no one is shown, or no one can predict who will progress. Those are some of the goals of our genetic studies and our other studies. If we could determine who will progress, who will end up with infertility, who will end up with advanced disease, we may be able to stratify who would do better with surgery versus medicines. Or I could ask you the question, how do we manage the woman whose mother had no pain but had stage 4 endometriosis, and she's the product of an IVF conception? Do we manage her differently than someone who has pain? Those are questions we do not know the answers to.